Welcome to today's deep dive. We have a really fascinating mission for this one. We're going to unpack the literal physical meaning behind the phrase, my head is pounding.
Right, yeah. It's a phrase we all use.
Exactly. And to do this, we're pulling from this stack of incredibly detailed clinical notes and surgical research from Dr. Adam Lowenstein, MD, FACS. He operates out of the Migraine Surgery Specialty Center, and his work essentially takes everything we think we know about tension and headache pain and, well, totally flips it upside down.
It really does. But before we jump into those clinical notes, we do need to establish a quick ground rule for everyone listening.
Oh, right, of course. Go for it.
The anatomical insights and, the surgical procedures we're going to explore in this deep dive are strictly for educational purposes.
Right, we're not giving medical advice here.
Exactly. Any medical decisions, diagnoses, or treatment plans always need to be made under the direct supervision of a qualified physician.
So keeping that in mind, let's talk about that phrase. My head is pounding. Right. You have a terrible, stressful day at work, you rub your temples, and you tell your family your head is pounding.
Yeah, we treat it as this colorful metaphor. It functions as our universal shorthand for misery,
Totally. It's just a figure of speech we use to say we're overwhelmed and tired.
Right. And when you use that phrase, people instantly understand the specific, unrelenting pressure you're trying to describe, even if they assume you're just being dramatic about a standard tension headache.
But going through Dr. Lowenstein's case files completely shatters that assumption. Because for a specific subset of people dealing with severe chronic headaches, it's not a metaphor.
Not at all.
They aren't being poetic. It is a literal mechanical description of an anatomical event happening inside their skull at that exact second.
Yeah, we're looking at a massive paradigm shift here in how we understand chronic pain. When patients with this specific condition say they feel a throbbing sensation, they are actually feeling the physical force of their own arterial blood flow.
Which is just wild to think about.
It is. They're feeling a blood vessel mechanically hammering against a delicate sensory nerve over and over, perfectly synchronized with their heartbeat.
I mean, that sounds like something out of a horror movie. A normal, healthy pulse is supposed to sustain life, not cause debilitating agony. How does an everyday heartbeat turn into a weapon against your own nerves?
Well, to understand the mechanics of that, we have to map out the geography of the nerves in your head.
Okay, lay it out for us.
Sensory nerves don't just, magically appear on the surface of your skin to let you feel the wind on your face.
Yeah.
They originate deep inside the complex tissues of your head and neck.
Right.
From there, they act like biological cables, threading their way outward to supply sensation to your forehead, your cheeks, your scalp.
And I'm guessing their path to the surface is not exactly a wide-open, empty highway.
Oh, far from it. The human head is incredibly crowded real estate.
I can imagine.
Yeah. So to get from deep inside your skull to the surface of your skin, these delicate nerve cables have to navigate some treacherous terrain. They're squeezing past heavy active muscles and poking through tiny rigid holes in the bone. And they're penetrating multiple layers of fascia.
Fascia, that's the stuff wrapping the muscles, yeah.
Right. Fascia is a dense, highly unyielding sheet of connective tissue that wraps around our muscles. Think of it like a very tight, tough biological casing.
Okay, so what happens when one of those pathways gets just a little too crowded?
That creates what surgeons call a peripheral trigger site.
A trigger site?
Yeah, it's essentially an anatomical bottleneck, a specific highly localized point where the corridor is too narrow and the surrounding structures begin to close in on the nerve, compressing it.
Right, and the notes actually detail two very different types of compression here, which I found fascinating. In a standard tension headache, the structure doing the squeezing is usually a muscle or a rigid band of that fascia we just talked about.
Exactly.
And from what I read, that creates a static compression, because if you have a tight, stressed muscle clamping down on a nerve, it's applying a steady, unyielding force.
Which matches the patient descriptions in Dr. Lowenstein's notes perfectly. They describe this imploding sensation like wearing a heavy iron band wrapped tightly around their skull. The pain is constant.
Because the pressure is constant.
Right. The baseline mechanical force of a tight muscle might fluctuate slightly over a few days, depending on your stress levels or how you slept. But the physical pressure on the nerve is essentially constant.
Okay, but vascular nerve compression introduces an entirely different mechanism.
It does. The structure crowding the nerve in a vascular trigger site is not a static muscle. It's an artery.
And arteries are incredibly dynamic.
Exactly. Because they're living hoses hooked directly to a pump.
Right, the heart.
Yeah, they don't hold a fixed rigid diameter. Every time your hurt muscle contracts, it sends a highly pressurized wave of blood.
The systolic pulse wave.
Right, surging out through your circulatory system.
Yeah.
And as that wave travels through an artery, the walls of the vessel have to physically expand outward to accommodate the sudden volume of blood. Then they relax.
So if a dynamic artery happens to share a microscopic doorway with a delicate sensory nerve, the nerve isn't getting a steady, static squeeze.
No, it is getting repeatedly struck.
Okay, let me see if I can translate this into something we can all picture. If you're trying to conceptualize this difference, imagine wearing a pair of shoes that are like a half size too small.
That's a good way to put it.
That's your muscular static compression. It's a dull, steady ache. You feel the unyielding pressure against your toes all day long, and it never really lets up.
Right.
But an artery physically expanding and hitting a nerve? What if we compare that to having a fresh, sensitive bruise on your arm and someone taking their index finger and just gently tapping it?
I think that captures the biological reality perfectly. A single gentle tap on a bruised arm isn't going to cause structural damage. The physical force of a single pulse wave expanding an artery is microscopic.
Ah.
But we have to factor in the sheer math of human biology. Your heart beats roughly 100,000 times a day.
Wow. That number just completely reframes the whole picture.
Doesn't it?
Because, yeah, if someone tapped their finger directly onto a sensitive bruise on your arm 100,000 times in a single day, the area wouldn't just be annoyed. The nerve endings would become so traumatized that eventually even the lightest brush of air would feel like absolute agony.
And the clinical term for that agony is severe hypersensitization. It's the core pathology of a vascular headache.
How does it happen on a cellular level, though?
Well, these nerves are lined with specialized microscopic structures called mechanosensitive nociceptors.
Okay, nociceptor meaning pain receptor.
Right. And mechanosensitive meaning they evolved specifically to fire an electrical danger signal to your brain the second they detect physical pressure or mechanical distortion.
Oh, what?
So because they're being struck and distorted by an expanding artery tens of thousands of times a day, the nerve just redlines. It reaches a state of severe chronic inflammation.
So eventually the completely normal, healthy pulse pressure of your own baseline blood flow.
Right, a sensation that a healthy, uncompressed nerve would completely ignore.
It crosses a threshold. It gets misinterpreted as a violent attack.
That's the tragedy of this condition. The nociceptors are doing their job, warning you of physical damage, but the damage is coming from your own heartbeat.
That is just brutal.
It is, which means when a patient sits in an examination room and says their head is pounding in perfect time with their pulse, they are actually providing the surgeon with a literal map of the physical environment. That specific nerve is trapped inside.
Okay, so if they're handing the doctor a map, where does X mark the spot? Where exactly in the head are these vascular collisions taking place?
Well, the clinical research identifies several distinct peripheral trigger sites scattered around the skull. But let's focus on the area most notoriously associated with this specific vascular pulsatile compression, the temporal trigger site.
Okay,
This is your temple region, basically the area just behind your eyes and above your cheekbones.
got it.
And the critical nerve structure navigating this specific neighborhood is a branch of the trigeminal nerve called the zygomaticotemporal nerve.
Okay, I know that's a pretty heavy medical term, but if you just take your index finger and trace a line from the outside corner of your eye slightly up and back toward your hairline, that's the general pathway we're talking about, right?
Yeah, that puts you right in the neighborhood. And tracing the path of that specific nerve under a microscope reveals exactly why it's so vulnerable to being crushed.
Because of the fascia.
Exactly. As it travels up the side of the head to provide sensation to your skin, it eventually has to pierce directly through a barrier, that temporalis fascia we mentioned earlier.
That unyielding, rigid wall of connective tissue.
Right. The nerve passes through is microscopic. It's a very tight doorway.
And from what the surgical notes describe, the conflict arises because the nerve rarely gets to go through that doorway alone.
Yeah, we see a major anatomical conflict at this exact junction.
Yeah.
A branch of the superficial temporal artery frequently runs adjacent to this nerve.
Oh.
They share the same crowded real estate. Often, they intertwine like vines, or the artery crosses horizontally directly over the nerve, right at the exact microscopic point where they both attempt to penetrate that rigid fascial wall.
So the nerve is essentially caught between a hammer and an anvil.
That is exactly it.
When the artery expands with the systolic pulse wave, acting as the hammer, the unyielding fascia directly behind the nerve acts like an anvil. The nerve has literally nowhere to retreat, so it just absorbs the blow and gets crushed.
The mechanical deformation is unavoidable. Now, the temporal region isn't the only place we see this specific conflict.
Oh, really? Where else?
The notes detail similar vascular collisions at the frontal trigger site, which involves the supraorbital and supratrochlear nerves located just above your eyebrows.
Okay, so forehead area.
Right, arterial branches often cross over those nerves as well, though the crushing force of heavy forehead muscles usually dominates the pain profile in that specific frontal region.
Gotcha. And the research also mentioned the back of the head, right?
Yeah, we see a major bottleneck at the occipital trigger site, located at the base of the skull and the back of the neck.
Okay.
The occipital artery threads its way up through some incredibly dense, heavy neck musculature,
Yeah.
and it frequently crosses directly over the greater occipital nerve, compressing it with every heartbeat.
Yikes.
But the temporal site, the side of the head, is where the artery is most frequently identified as the primary, solitary antagonist causing the pain.
Wait, hold on. I have to ask a practical question here. You're describing anatomical bottlenecks that are microscopic. They're buried under layers of skin, fat, and heavy muscle. If I walk into a clinic with a terrible blinding pain in my temple, and my neck and jaw muscles are incredibly tight from stress, how on earth does a doctor distinguish between a pounding artery and a tight muscle? I mean, they literally share the exact same microscopic space.
It is an incredibly complex diagnostic challenge, and it requires careful detective work.
So where do they even start?
The physician usually starts with meticulous symptom tracking. A muscular tension headache might start as a dull ache in the morning and worsen slowly as the day drags on and your posture deteriorates at your desk.
Right, classic tension headache.
But a vascular headache behaves very differently.
Yeah.
It responds rapidly to cardiovascular changes. The clinical notes point out that physical exertion or even a sudden fever causes this specific type of headache to spike violently.
Well, because physical exertion forces your heart to pump harder and faster.
Exactly.
The systolic pulse wave traveling through your arteries becomes larger and significantly more forceful, which means the arterial hammer is striking the nerve that much harder.
The mechanical force increases, so the pain increases. Furthermore, a skilled physician examining the patient might actually be able to palpate or physically feel a prominent superficial temporal artery visibly throbbing right at the nexus of the pain. The gold standard for proving the exact location of the collision involves diagnostic nerve blocks.
Nerve blocks, okay.
The physician uses a highly targeted injection of local anesthetic to selectively numb the specific nerve in question. Say, the zygomaticotemporal nerve we were discussing earlier.
Oh, it's kind of like walking down to the breaker box in your basement when the power goes out. You start flipping switches, turning off the sensory pathways one by one to see exactly which circuit is overloaded and causing the system to crash.
That is exactly how the diagnostic process functions. If the pounding, debilitating pain completely vanishes while that specific block is active, the surgeon has confirmed the exact anatomical corridor where the nerve is being crushed.
They've isolated the circuit.
They have located the exact millimeter of tissue where the hammer is hitting the anvil.
But there is a massive flaw in the breaker box analogy. An anesthetic block is just a temporary snooze button.
Yep.
It wears off in a few hours. The biological switch flips itself back on, the numbness fades, and that arterial hammer is guaranteed to wake back up and resume striking the nerve. So if the nerve block only proves where the collision is happening, what is the actual permanent fix here?
The overarching objective of the surgical solution is to permanently separate the delicate sensory nerve from the pulsatile pressure of the blood vessel.
Okay, how did they do that?
The surgeon uses the same small, heavily concealed incisions they would use in a cosmetic procedure or to release a tight muscle. But the real complexity happens under surgical magnification.
Right.
They perform a meticulous dissection, gently freeing the delicate nerve fiber and tracing its path, millimeter by millimeter, to locate the exact crossing point where the artery is doing the damage.
Once they find that exact point of collision under the microscope, what does this all mean for the artery? Because my first instinct, if I'm looking at a tube pressing on a wire, is just to nudge the tube out of the way. Just move the artery a few millimeters to the left, create a little buffer zone for the nerve, and close up the incision.
And leaving the artery intact and just repositioning it is a very common first instinct, even for some medical professionals. But it ignores the fundamental biological reality of soft tissue.
Which is?
Soft tissue inside the human body is highly dynamic. It constantly remodels itself over time, and more importantly, it has structural memory.
It's kind of like leaving a heavy garden hose in a mud rut in your backyard.
Oh, I like that.
Let's say you have a hose running across your lawn, and it's been lying in the exact same spot for a year, pressing directly down onto a delicate landscape lighting wire. If you walk out there and simply nudge that hose 2 inches to the left, you haven't really solved the problem, right?
Right. Why wouldn't moving it solve the problem?
Because the mud has already formed a deep grooved rut around the hose. As the ground shifts over the next few weeks and water pressure pulses through the hose, making it vibrate and move, gravity is just going to pull it right back into that same muddy rut.
Exactly.
It's inevitably going to slide back down and rest directly on top of the wire again.
That analogy perfectly captures why repositioning fails in the human body. The temporalis fascia and the surrounding tissues in your head have that exact same structural memory.
Wow.
If a surgeon just pushes the superficial temporal artery aside, the natural tension of the tissues, combined with the constant, forceful pulsing of the blood wave, will cause that vessel to migrate over a few months.
It just finds its way back.
It will slide right back into its original anatomical rut, directly against the nerve. So you cannot just move the physical structure creating the pulse.
Which means if you can't move it, you have to snip that section of the garden hose out of the yard completely. You have to permanently eliminate that segment of the artery.
Yes. The surgical technique detailed in the clinical notes is known as bracketing, dividing, and excising the vessel.
Okay, break that down for us.
Now, a surgeon cannot simply cut an active artery or it would hemorrhage immediately.
Right, obviously.
First, they bracket the troublesome segment. Under heavy magnification, they place secure stops using precise heat cautery, surgical ligatures, or tiny titanium clips at 2 distinct points.
Okay.
They place one clip just upstream of the nerve crossing and one clip just downstream.
So they isolate and completely seal off that specific tiny segment of the vessel that's causing the problem.
Right.
And once it's sealed, they divide it and physically excise, meaning they resect or remove, that tiny piece of the artery from the patient's head, completely freeing the nerve.
Exactly. Once the arterial segment is removed, the nerve is thoroughly re-inspected under magnification. The surgeon meticulously checks all angles to ensure absolutely no other microscopic vascular branches or tight muscular bands are touching it before the incision is finally closed.
Wait, hold on. Did you just say they cut a piece of an active artery out of the head?
I did, yes.
I have to pause here because if you hear the phrase arterial excision, your brain probably immediately goes to the absolute worst case scenario.
Naturally.
You hear a surgeon is permanently cutting and removing a section of an artery near your brain, and the immediate fear is that you're cutting off oxygen to your brain or that the skin on your scalp is going to die. I mean, you can't just gloss over removing blood vessels.
No, that anxiety is entirely understandable, and it's usually the first question patients ask. But that fear stems from a common misunderstanding of how our cranial plumbing is actually laid out.
Okay, clarify the plumbing for us.
To understand why this surgery is safe, we have to separate the internal circulatory system from the external circulatory system. The massive vessels supplying blood and oxygen to your brain are heavily protected, routed deep inside your neck and skull, and they are completely isolated from the peripheral vessels we're talking about here.
So the superficial temporal artery, the occipital artery in the back of the head, all these tiny vessels at the peripheral trigger sites, they have absolutely zero connection to the internal carotid system that keeps the brain and the eyes functioning.
They have zero connection to the brain.
Wow.
They are terminal branches of the external carotid system. Their sole evolutionary purpose is to feed the soft tissue, the subcutaneous fat, and the skin of the face and scalp. So the brain is 100% safe from this procedure.
Okay, but that still leaves the scalp. If you physically remove a section of the superficial temporal artery to save a nerve, how does the skin on the side of your head survive without that blood flow?
It survives because the human scalp possesses one of the most brilliantly redundant blood supply systems in the entire human body.
Redundant meaning backups.
Exactly. It relies heavily on a biological safety net called collateral circulation. The blood feeding your forehead, your temples, and the back of your head does not arrive through one single isolated pipe. It is delivered by a highly dense, overlapping network of arterial branches arriving from all directions.
This makes so much sense. It's essentially functioning exactly like the street grid of a major city.
Right.
If a water main breaks on a small residential side street, the city dispatchers close down that one single half-block alleyway to fix the pipes. The entire city doesn't paralyze.
No, they just go around.
The cars, or in this case the blood, simply divert to the overlapping avenues, the boulevards, and the adjacent side streets. The traffic distributes itself seamlessly across the remaining grid, and everyone still gets to their destination.
Collateral circulation works exactly like that city grid.
Right.
Excising a small, millimeter-long segment of the artery isn't shutting down the interstate highway. It is simply closing an alleyway.
Right.
The surrounding side streets possess more than enough capacity to absorb and redirect the flow of blood to the scalp. And this concept of anatomical redundancy is deeply established in medical practice.
Really? Where else do they do this?
Surgeons in other medical disciplines routinely perform temporal artery biopsies, where they entirely remove large segments of these exact same vessels for testing, with absolutely no damage to the survival of the scalp.
And the surgeon performing this migraine procedure doesn't just cross their fingers and hope the grid handles a detour, right? They visually verify the traffic is flowing.
Oh, visual confirmation is a mandatory step in the operating room. Before closing the incision, the surgeon closely inspects the surrounding tissue.
Right.
They confirm that the skin color remains perfectly pink and healthy. They verify in real time that the collateral perfusion is actively feeding the area from other directions, while the freed nerve is finally allowed to exist in a silent, pressure-free corridor.
Man. Pulling all of this together, what we're really talking about today is a profound shift in how we view chronic pain. Debilitating pulsatile pain is not always just a stress reaction or a muscle spasm you can massage away.
No, it is not.
It can be a literal mechanical anatomical collision. And finding permanent relief requires a comprehensive surgical mapping of everything: the muscles, the rigid fascial walls, and these dynamic pulsing arteries.
And this remarkable synthesis of structural anatomy and surgical logic comes directly from the ongoing work of Dr. Adam Lowenstein, MD, FACS, at the Migraine Surgery Specialty Center.
Such fascinating work.
Truly, for anyone looking to explore the mechanics of these procedures further, or to understand the diagnostic process we outlined, headachesurgery.com is a tremendous resource. It provides a deep dive into how isolating and physically removing the mechanical trigger changes lives.
It fundamentally changes how you view the inner workings of your own body. We started this deep dive talking about how a pounding head is used as a metaphor for a stressful day. But for these patients, a trapped nerve is literally misinterpreting the perfectly normal, life-giving rhythm of their own pulse as a violent physical attack.
Which is just incredible to think about.
It really is. Which leaves you with a pretty wild, mind-expanding question to ponder long after this is over. Considering how easily a nerve can be fooled by a crowded anatomical pathway, what other perfectly normal, healthy physiological rhythms humming away inside our bodies right now are being completely misread as pain simply because our internal wiring has gotten a little too cramped? Keep that in mind the next time you find yourself rubbing your temples.